Our talk today is going to cover 2 lectures on interceptive orthodontics. And the references were already uploaded on your e-learning website. Chapter 3 from Laura Mitchell. And so chapter 3 from Laura Mitchell, 5th edition. So please make sure that you actually downloaded the 5th edition because the old one was the edition before. I updated this a few days ago. And the other reference for you is this guideline. This is an article published in the British Dental Journal in 2014. And these guidelines were actually extracted from the original guidelines from the Royal College of Surgeons of England, and published in the same year. But in this article, I thought they actually presented photos, radiographs, and it was much more constructed and easier to read for you. So this is a must for you to read. And this article on interceptive orthodontics, the current evidence-based best practice, published in the Dental Update in 2013. So these are our references for both lectures. And we're going to start by defining what do we mean by interceptive orthodontics. Well, according to Richardson in the 1982, it means the prompt treatment of unfavorable features of a developing occlusion. When we say developing occlusion, it means that we are applying this treatment for children. They are still growing. Okay, developing occlusion, we mean that we are going from the deciduous dentition to the permanent dentition, so most probably in the mixed dentition stage. The reason why we're doing this to achieve a satisfactory results by simple mechanics later, thus reducing overall treatment time and providing better stability and functional and aesthetic results. Right, according to Ackerman and Profit, we're doing this in order to fully correct the developing malocclusion in 15% of those children, or improve the condition and reduce the severity in 49% of the cases. So if we ask the question, is it worth to undergo the interceptive orthodontics and manage those patients at an early age? Yes. Yes, it is worth it. 15% will have fully corrected malocclusion. 49% will have an improved malocclusion. So this is a lot. This is good. So what do we need to do in order to apply interceptive orthodontics? We need knowledge. We need to be able to differentiate between what's normal, what's considered a normal development, and what's not. If we are able to identify what's not, then we will go to the next step, and that is diagnosis. We will go into further examination, extraoral, intraoral examination, proper diagnosis, maybe further radiographs, further records in order to get the proper diagnosis. And after that, we need to understand why do we need to apply treatment now, such in an early age, and why. We will understand why by trying to imagine if I leave the condition as it is, untreated, what are the consequences? And this will answer this question. What's going to happen? The last thing we need to know is how am I going to treat that patient and apply the interceptive measures. Now, as 4th-year students, you already had your basic knowledge in your first semester, and of course now in the 2nd semester in terms of the theory, in terms of lectures. You already covered the normal craniofacial growth and development. You already covered the occlusal development, extraoral, intraoral examinations, etiology of malocclusion, especially the 2 lectures on local factors, URA, upper removable appliances, the 2 lectures, functional appliances, the 2 lectures. All these lectures will be handy when we talk about the interceptive orthodontics. All this theoretical knowledge will come together in this lecture. So we're going to talk about supernumerary teeth, hypodontia, early loss of deciduous teeth, retained deciduous teeth, infra-occluded primary molars, Natal tooth, failure or delayed eruption. First molar of poor prognosis, this is very important. Non-nutritive sucking habits, spacing, crowding, crosspipe, increased overjet. So any condition we're going to talk about, we're not going to talk about the definition, the classification, the epidemiology, etc., because this was already covered in the lectures on local factors. So we're going to try to talk maybe about consequences, and straight away we will go to the management. So supernumeraries here, the management of patients in early age that presents with supernumerary will depend on the clinical presentation, will depend on how the patient actually presented to you in your clinic. Usually there are three different pictures. The first one, patients with fully erupted supernumeraries, and usually they will look like this, mesodense or supplementary. If this is the case and they are causing displacement of adjacent teeth, they're causing crowding, maybe associated problems, periodontal problems, etc., it's important to extract it. The extraction is straightforward. If the tooth is a supplementary tooth, then here we need to think carefully. We need to remove the tooth that is of poor prognosis, for example, that had a trauma, or restorations, or cavity, or periodontal problem, or the most severely displaced one. So here this patient has 3 central incisors. So and the 3 of them are sound. They have no problems in terms of restorations or cavity or periodontal problems. So we choose the one that is most severely displaced, and it's usually this one that is labially displaced. So this is if we have a fully erupted tooth. If we have an impacted tooth that is associated with problems, usually impaction or maybe pathology or whatever, then we might need to go for surgical extraction. So we need to raise a flap, dig some bone, and then just extract it. Here an example, a young lady, 8 years old, she came with a delayed eruption of the lower right lateral incisor. So here we have centrals, both centrals, and we have the lateral on the left side, but the right side, there is delayed eruption, and as you can see, there is actually bulging palatally. A cone-beam CT scan showed that the patient had 2 supplementary supernumeraries, actually one impacted on the left side, asymptomatic, and the other is on the right side. And so the decision, of course, was to remove the most severely displaced and review the patient in 6 months in order to review normal eruption of the lateral on the right side. The third picture for patients with supernumerary are asymptomatic cases that are diagnosed by accident. Most of those cases are patients who come to our clinic seeking orthodontic treatment, and as we go through our basic examination, screening with an LPG, we are surprised with some supernumeraries that are sitting there in the bone, causing no harm. But if the patient is planning for orthodontic treatment, these supernumeraries should be extracted. If the patient is not planning for orthodontic treatment, we might keep the supernumerary monitored. Every year, for example, we can take an LPG, but if it's close to the teeth, then most probably it will need extraction. The opposite condition is hypodontia, congenitally missing teeth. Management of hypodontia in early age will depend on which segment is being affected. If it's the anterior segment, then luckily most of the cases will have an early diagnosis because it is the aesthetic zone. In the lower arch, the most commonly affected tooth are the central incisors. If the patient is having central incisors congenitally missing, then it's important to maintain the deciduous incisors, as long as possible in order to maintain healthy bone, so that in the future, if the patient requires prosthetic replacement, then these could be extracted and an immediate implant could be positioned. If the patient is presented with a class 3 malocclusion, then we need to refer the patient to the orthodontist because sometimes the extra space provided by the missing tooth could be used to camouflage the malocclusion. If the missing tooth is in the upper arch, in the upper anterior segment, then most probably it is the lateral incisor. If it's the lateral incisor, then we need to be careful because patients with congenitally missing lateral incisors will have a higher risk of palatally impacted canine. So we need to go for the basic examination of the canine, and usually that is the buccal bulging between 8 and 10 years of age. The canine should start to bulge buccally. If they don't, then we need to take radiographs in order to exclude the risk of palatally impacted canines. If the canine showed risks of impaction, then we might need to extract the B and or the C in order to encourage the canine to normalize its path of eruption. So this patient here, you can see that we have congenitally missing lateral incisors. This is a retained B on the left side, this is a retained C on the right side, and these are palatally impacted canines. Now, if the congenitally missing tooth is in the posterior segment, unfortunately, we will have late diagnosis because usually the patient will come and we will diagnose them by accident because it doesn't really affect the aesthetic. If it's in the lower arch, again, we at an early age, we try to give the parents and the patients excellent oral hygiene instructions to maintain excellent tooth condition in order to maintain the E as long as possible. And actually, it sometimes could survive 15 to 20 years. So that in the future, if the patient loses the E, then they can have good amount and quality of bone in order to go immediately for an implant. If the patient presented with a class 3 malocclusion, it's important to refer to the orthodontist because they might use the space to camouflage the malocclusion. If the missing tooth is in the upper arch, then again, we maintain excellent oral hygiene. We try to assure excellent tooth quality so that the E could retain and could survive as long as possible. And then in the future, they can replace it with an implant. If the patient is presented with a class 2 malocclusion, then it's important to refer to the orthodontist because the orthodontist might use the space to camouflage the malocclusion at an early age. Now we're going to come to premature loss of deciduous teeth, starting with the incisors, centrals or laterals, it doesn't matter. Usually the effect of a premature loss, when we say premature loss, it means early, before its time. If we have an incisor, deciduous incisor is missing, usually it will have minimal effect on center line, minimal effect on space condition. But it's important to understand why was this tooth missing, why we missed this tooth. Unfortunately, the most common cause is trauma. And if it's trauma, it's important to report this in the patient's records and inform the parents that this will increase the risk of developing Turner tooth, like here, this is a Turner tooth, or dilaceration, or thickening of the gingiva and delayed eruption of the permanent tooth. That is the central incisor. Since we're talking about dilaceration, it's important to talk about the management. So if the patient is presented with dilaceration, usually it goes unnoticed, especially if it's mild. It will not cause any problems. But if it's moderate or severe, it might cause delayed eruption or even impaction. And if it's really severe, we might need to extract that dilacerated tooth. So if we have premature loss of a deciduous incisor, the management is nothing. We just reassure the parents and we just make sure that they are properly informed about these risks, and we just follow up the patient every 6 months, the usual dental checkup. Premature loss of canines, on the other hand, deciduous canines, usually lead to midline shift. And it will lead to loss of space of the permanent canine, and this will lead to its impaction or severe displacement. Unless the arch is spaced, we have plenty of space, then the center line and the other consequences should be minimal. So to prevent such consequences that we talked about, it's important to go for balancing extraction. So here's a patient with upper center line discrepancy, and the reason is due to an early loss of E on this side. And then you can see bulging in the buccal segment because the canine has no space to erupt. This is another example of localized crowding in the upper right quadrant, and the etiology is an early loss of C on one side. No balancing extraction was carried out on the other side. A third example is this arch here. So we have the C on the right side, partial erupted 4, and E. On the other side, we have lateral incisor, and then immediately the 4, and then the E. Where did the canine go? Well, the deciduous canine was early lost, premature loss, and then we have an impacted canine because the space was lost and central line shifted to the left side. Premature loss of deciduous first molar, well, its effect will depend. It might affect central line, it might affect the space for the erupting premolar or sometimes the canine, depends on the sequence of eruption. If the arch is spaced, we have plenty of space, these consequences will be minimal and we just need to keep the patient under observation. But if there is any tendency of central line discrepancy or loss of space, we need to go immediately for space maintainer. And usually we go for a band and loop type of space maintainer. As we said, consequences will depend on the amount of crowding and the position of tooth that we have lost and the sequence of eruption, of course. Premature loss of deciduous second molar most probably will be associated with an immediate mesial shift of the first permanent molar. And this will lead to loss of space for the erupting second premolar, most probably impaction or severe displacement. So this is a patient with an early loss of E on both sides and an impacted 5 on both sides. This case here, we have an early loss of E on the upper left quadrant. And as you can see, the 5 was not impacted, but it was severely displaced due to lack of space. So what should I do? What's the management? Again, we need to go for band and loop type of space maintainer. If the problem is bilateral, then we go for lingual arch in the lower arch or transpalatal arch in the upper arch in order to preserve space bilaterally. Now, the problem is not an early loss, the opposite, retained deciduous teeth, a tooth that stayed in its position more than 6 months after the eruption of the contralateral tooth. If we have retained tooth, what are the consequences? Well, we might have impaction of the permanent successor, or we might have severe displacement of the permanent successor. So why, in this case, the canines are severely buccally displaced? Because of the retained deciduous. What's the management? As soon as you identify and diagnose the retained deciduous teeth, you need to take radiographs to make sure that teeth are present, there is normal dental development, and then you go for extraction of the deciduous tooth and review the patient to make sure that the permanent successor is erupting as planned, in a normal dental development. Another problem that could be addressed early through the interceptive orthodontics, and that is the submerged primary molars. Submerged primary molars. Well, the management of such a case will depend on the severity. As you know, it is classified to mild when it's above the contact point, moderate if it's around the contact point, and severe if it's below the contact point. Well, luckily, most of those cases goes unnoticed. They will be corrected spontaneously. No need for any further treatment. Just review the patient. But sometimes few cases will go through more severe and progressive in submerging. And it's important to review the patients and extract the submerged EF. There is a risk of disappearing below the gingiva because that will make the extraction more traumatic and more severe. If the root formation of the permanent tooth is near completion, then it's important to extract it and allow normal eruption of the permanent successor. Or if you have missing permanent successor and the submerging is progressing. In this case, it's important to refer to the orthodontist because, again, the orthodontist might use the space to treat the malocclusion, relieve crowding, camouflage the malocclusion, depends on the position of the tooth. This is, I think, in your reference, one of the articles that we talked about in the dental update, you will have a table that summarizes the management of such cases. Now we will come to natal tooth. A natal tooth is a tooth that has erupted at birth. If after birth, then it is called neonatal tooth. Now, the management will depend on the amount of mobility. If it's a lot, if there's a lot of mobility, that will carry the risk of inhalation, or it will interfere with breastfeeding, then there is no other way, we have to extract it. Otherwise, if you leave it inside for a few weeks, it will get firm by itself because the root will develop quickly. Either way, it's important to inform the parents that this is usually, most of the cases, this is part of the deciduous dentition. This is part of the normal dentition. So if it's extracted, this has to be properly documented in the patient's records so that in the future, the patient should not be misdiagnosed with hypodontia. So if you extract it, you have to document this properly. Another problem that could be diagnosed early and having a proper management early is the failure or delayed eruption of teeth. Now, how do I identify this problem and diagnose it? By disturbance in the sequence of eruption. So for example, if the lateral incisor in the upper arch erupts before the central incisor, that means there is something wrong with the central incisor. So this is disturbance in the sequence of eruption. Or asymmetry in eruption. So if for example, the canine erupted on one side and 6 months later, the other side did not erupt, then this is a problem. But if the problem is generalized, so if we have generalized acceleration of eruption or generalized delay of eruption up to 2 years, is okay. It's considered normal. Just review the patient and make sure that all teeth are present within the bone and the dental development is going through its normal stages. So the most commonly affected teeth by delayed eruption, excluding of course third molars, usually the maxillary canines, the central incisors in the maxillary arch, and the first permanent molars. Here we're going to talk about the first permanent molars because they erupt first. Again, luckily, most of those cases, ectopic sixes, they call it ectopic sixes, will resolve spontaneously. They will go unnoticed. On the other hand, some will progress and it will become severe and they will need active treatment. The ectopic molars are usually classified into mild, moderate, severe. Again, it depends on its position relative to the E and if there is any signs and symptoms or resorption of the adjacent E. So if the patient is younger than 8, usually we go just review, and most of the cases, as we said, goes spontaneously resolved. But if the patient is after 8 years of age, then we need to have an active treatment. We start with something simple. We start with separators, like here. Separators, they could be metal, they could be elastic separators, and every 2 weeks the patient comes for us to retighten, reactivate, and we keep doing this for 2 months. And usually it works. Usually most of the sixes will unlock from underneath the E, but on other cases they will not respond. Like here, for example, this is a severe ectopic six to the extent that it has, as you can see, severe resorption of the E. In this case, we have to go for extraction of the E, wait until the six fully erupts, and then handle the problem of space loss. Because we know that the space for the 5 was lost, and we might be faced with the higher risk of impaction of the second premolar. So we will handle the loss of space later. Now we will come to the maxillary incisors. Unerupted maxillary incisors, the most common cause of delayed eruption is supernumerary, the tuberculate type, and luckily 90% of those patients, if you remove the obstacle, the tooth will erupt. To manage those cases, it's important to refer to this table from Dental Update, the article that is provided for you as a reference, and they actually use the Royal College of Surgeons of England guidelines for the delayed eruption and impacted maxillary incisor. The management will depend on the age. Younger than 9, it's important to go through removal of the obstacle, provide the space, wait 18 months. Above 9 years of age, then again, we remove the obstacle, you know, if it's supernumerary, if it's fibrous tissues, whatever the problem is, we provide the space and then we wait 12 months. If the patient is over 10 years of age, then we remove the supernumerary, we provide the space, and we immediately go for surgical exposure and traction. There is no time to waste. Okay, so the management will depend on the presence of obstacle, presence of space, and the age of the patient. And the age of the patient will actually affect the stage of development of the root. Okay. Now, what about the maxillary canine? Maxillary canine, as we said, we need to feel the bulge of the maxillary canine buccally between 8 and 10 years of age. If it's not there, or if it's asymmetrical bulging, then it's important to go for further investigation, panorama, cone-beam CT scan, depends on the case. Patients with congenitally missing lateral incisor, patients with family history of dental anomalies, most probably we need to go for this screening of OBG and cone-beam earlier because these problems usually run in the family. They are congenital. So the management is, in most of the cases, is to extract the C in order to help the canine to normalize its path of eruption. The extraction, within 6 months, 64% of those cases will normalize, will go back to their normal path of eruption. If we wait 12 months, 78% will normalize. But beyond that, we rarely will have any cases progressing well. So it's important to go for active orthodontic treatment, exposure, traction, depends on the case. Now we will come to the case of 6 of poor prognosis. Again, go back to the article that we gave you as a reference. These guidelines have lots of terminologies. It's important to get used to the terminologies involved. So if we say first permanent molar of poor prognosis, what do we mean is a tooth that has at least 2 surface area of cavity or of filling, or a tooth that has enamel hypoplasia, for example. These molars are called poor prognosis, having poor prognosis. Another difference that we need to make sure that we understand is the difference between elective and enforced extraction. When we say elective extraction is a planned extraction that sometimes involves sound tooth, a tooth that is having no fillings, nothing, sound tooth, a tooth with good quality. Enforced extraction is an extraction of a tooth with poor prognosis that we have no other alternatives. It's causing lots of problems. There is no other alternatives. We are forced to its extraction, okay? We have to extract it. Another terminology that you need to be familiar with is the optimal time of extraction. Optimal means the ideal time to extract a 6 with poor prognosis and expect minimal consequences. This is what we mean by optimal time. Before that time, this is called early extraction. After that time, this is called late extraction. And of course, you know what balancing and compensating extraction is meant. Here, we're going to talk about optimal time for extraction of the 6 with poor prognosis. Optimal time, as we said, is the time when we extract the 6 and expect the 7 to replace it beautifully with minimal consequences. We will talk about the consequences in a minute. This time is usually, from a chronological point of view, is usually between 8 and 10. From a radiographical point of view is when the bifurcation area of the 7, of the developing follicle of the 7, is just about starting to calcify, like this here. And when the angle between the long axis of the 6 and the long axis of the 7 about 15 to 30 degrees, and when the developing follicle of the 7 is overlapping with the distal root of the 6. These criteria will give you perfect time to extract this badly destructed 6, as you can see here. This is a 6 with at least two surface area of restoration. And actually, this case has also early loss of E. There is no space for the 5. The 5 is almost impacted here. Okay? So if we extract this 7, we should expect to have good results. So this is the case. This is the case with the radiograph. This is the 6 that we were just talking about. And this is the early loss of E, and the 5 is actually impacted here. I just want to show you the upper 6 here that has only one surface area of cavity. So we didn't consider any extraction of that tooth. So we extracted the lower one at the optimal time. And this is few months later. Unfortunately, when the patient came back to review the eruption of the 7, we found that the upper 6 now is of poor prognosis, so we had to extract the upper 6 as well. As you can see here, about less than 2 years, the 7 had erupted beautifully in the place of the 6, as if there was no missing 6 in this area. The 5 erupted, we had resolved the crowding, severe crowding. The 5 erupted, the 7 erupted with minimal consequences. And the upper also, we have a new tooth. This is the 7, replacing the 6 with minimal consequences. So this is what we call optimal timing of extraction. If we extract the tooth before the optimal time, this is early extraction. The consequences of an early extraction is a second premolar that will drift distally, tip, and rotate into the extraction space. The labial segment will actually retrocline, and it will cause increase in the overbite, and sometimes it will cause center line discrepancy if the early extraction was on one side only. On the other hand, late extraction, if I extract the 6 in the lower arch after the optimal time, the consequences is the 7 will actually tilt mesially and will lingually roll. And we will have the 6 in the upper arch will over-erupt. We will have distal drifting of the 5, incomplete space closure, and sometimes atrophy of bone. In the upper arch, the consequences are usually less severe, and we rarely have lower 6 over-erupting if we lose the upper 6 early. As a general rule, it's important to understand, as a general dentist, you need to understand that if you are faced with a 6 of poor prognosis and the space for this 6 is not critical for orthodontic treatment, for example, to relieve crowding, to camouflage certain malocclusion, to reduce an overjet, for example. If this is not critical, then you need to choose the optimal time for extraction in order to allow the 7 to replace the 6 beautifully with minimal consequences. Patients with a class 1 malocclusion, and this is all in the guidelines that was provided for you. Patients with a class 1 malocclusion with minimal crowding, you can extract the 6 at the optimal time. You don't need to balance, and you only compensate if you extract in the lower arch. If the patient is presented with crowding that is located in the buccal segment only, then again, you go for the optimal time of extraction. And if you have crowding on the other side, then you can extract. This is what we call elective extraction. You can extract on the other side, so we go balance extraction. Even if the 6 on the other side was sound, of good quality, no filling, it's okay. We need to preserve the symmetry. We need to relieve crowding. So you can go for balancing extraction, and you compensate only if the extraction was carried out in the lower arch in order to avoid over-eruption of the upper 6. If the crowding was not in the buccal segment, it was in the labial segment, then we need to stop here because extraction of the 6 will not allow spontaneous relief of crowding. If I need the space to relieve crowding in the labial segment, then I need to wait until the 7 is fully erupted. Then I extract the 6 and I use the space orthodontically in order to relieve crowding. This is important. Patients with a class 2 malocclusion, in the lower arch, if I have a 6 of poor prognosis, then I try to extract it at the optimal time, and we avoid any compensating or balancing extraction. In the upper arch, on the other hand, space is needed to camouflage the malocclusion. We need the space in the upper arch to reduce the overjet, maybe relieve crowding. So it's important to avoid extraction until the 7s are fully erupted, and then we hold the 7 using maybe removable appliances, functional appliances, TBA, depends on the case, and then we extract the 6 and use the space orthodontically in order to correct the malocclusion. If the case presented with crowding, then in the lower arch, we try to avoid extraction until the second molar is fully erupted, and then we use the space to relieve crowding. Or if the third molar is present, if the wisdom is there, I can see it on the OPG, then we can extract the 6, but inform the parents that in the future we might need to extract the premolar, another tooth. In the upper arch, again, the same. We need to avoid extraction even at the optimal time because I need space for orthodontic treatment. So we wait until the 7 is fully erupted. Then we maintain the 7 in place using, as I said, whatever appliance I have, removable appliance, functional appliance, TBA, according to the case. And then we extract the 6 and use the space to reduce the overjet and correct the malocclusion. In class 3 cases, you need to be very careful. Extraction of the maxillary molars should be avoided. Balancing, compensating extractions is not recommended. Ideally, if the patient is a class 3, then you need to refer the patient for the specialist orthodontist, and then they will refer him back to you if any extraction is needed or needed to be postponed. Class 3 malocclusions don't extract. So now we're going to come to another problem that could be actually treated early, and that is the non-nutritive sucking habit. You already know sucking the thumb will cause malocclusion. You already know the mechanism. You already know the features of this malocclusion. Here, we will talk about an early treatment to stop this problem. So, the patient is younger than 7. We should start with non-physical methods to stop this habit. So we can go for positive reinforcement, habit reversal, reframing of the habit, non-physical methods. Or we could use plasters, gloves, bitter flavored agents, and nail polishes. And we need to use these non-physical methods 3 to 6 months maximum. If the patient is not benefiting from this non-physical method, then we need to move on to the actual appliance. We need to fit an appliance to stop the habit. We call it fixed habit breaker appliance. It's like a transpalatal arch, but it will extend anteriorly, and then we have vertical loops in order to avoid being able to fit the thumb in the palate and go for sucking. Okay? If we fit this appliance, we need to make sure that it should be used at least for 6 months to make sure that the habit has stopped or terminated, and we can continue 6 to 12 months according to the case. Now we will come to another method to treat a malocclusion early, and that is extraction of deciduous canines. There are special indications for the extraction of deciduous canines. We already explained 2 of these indications. Number 1, if you have a canine with high risk of palatal impaction, as we said, you can go for an interceptive extraction of the C to help the canine to normalize its eruption back. The second case that we talked about was the balancing extraction. So if you lose the canine, deciduous canine on one side, and there is a risk of midline shift, then you need to extract the canine on the other side in order to preserve the midline. Another cases where we need to extract the C are cases with crowding, especially for the lateral incisor that erupts palatally with not enough space to accommodate it. So we extract the C and we use removable appliance to push that tooth across the bite to its normal position. Another case or indication is when you have crowding that is localized to the labial segment, then you can extract the C and allow spontaneous alignment of the labial segment, but you need to be careful because you only shifted the crowding from the labial segment to the posterior segment. So you need to deal with the problem later when the canine premolars erupt. You can use this also if you have an incisor that is periodontically gingivally compromised. There's gingival recession due to crowding and displacement labially. In this case, you can extract the C and expect collapse of the lower labial segment. They will retrocline into the provided space, and this should minimize the gingival recession and help with the health issues related to the periodontium tissues here. Sometimes in patients with a class 3 malocclusion, we could extract the Cs, but again, we need to deal with the problem of crowding in the buccal segment later on. So these are the indications, special indications to extract deciduous canines early into the developing occlusion in order to minimize the features of developing malocclusion. Now we will come to the problem of crosspipe, and here we're going to start with the anterior crosspipe. Anterior crosspipe could involve a single tooth, 2 teeth, 3 teeth, or the whole labial segment. More teeth involved in the anterior crosspipe, the more severe the consequences of no treatment. So if you don't treat this case here, for example, what will happen? First of all, we will have attrition of the labial surface of the upper incisors. We might have fracture or mobility of teeth involved in this traumatic occlusion. We will have compromised aesthetic, development of a class 3 profile, gingival recession, as you can see here, gingival recession at the lower incisors due to this traumatic occlusion. So all these are the consequences of having no treatment. So what should we do? We need to treat as soon as possible. We can use simple removable appliances, or we can use 2x4 fixed appliance, and we will talk about this in a minute. The first thing we need to do to manage such cases, first, we need to make sure that this tooth in a crossbite has enough space to be pushed across the bite labially. Number 2, we need to make sure that the overbite, which is the vertical overlap after we correct the crossbite, is enough to stabilize the results. Number 3, we need to make sure that within the arch there are enough undercuts, enough teeth with undercuts in order to retain the appliance in place. Now we will come to the crossbite that involves 3 teeth or more. 3 teeth or more. So if we have a single tooth, what type of active component we can use? Z-spring. If we have 2 adjacent teeth in a crossbite, we can use double cantilever, 0.6 millimeter stainless steel wire. If we have 3 teeth or more, then we need to sit and think about the case. There are 3 important things we need to check. Number 1, is this anterior crossbite associated with mandibular displacement, anterior mandibular displacement, or not? Number 2, does the patient has family history of class 3 malocclusions with strong and prognathic mandible or not? Number 3, the overbite is positive, is increased to enhance stability or not? I will show you here a video explain what do we mean by anterior mandibular displacement. This is opening, closing, edge to edge, and then anterior mandibular displacement. So when the patient bites edge to edge, this is considered premature contact. And to avoid this, the patient tries to go with anterior movement of the mandible. So this is what we call pseudo class 3. It's not a real class 3 because the patient can bite edge to edge, and this is a premature contact, and then the mandible is forced forward to avoid this premature contact. This is anterior displacement of the mandible, and this is what we call pseudo class 3 malocclusion. So how can we make sure that treatment results is a success? Well, number 1, if the patient is having anterior mandibular displacement, what we call pseudo class 3, this is excellent. This is good because it means that the class 3 that we see is actually less severe than the real malocclusion is less severe than what we see inside the patient's mouth. If the patient is having no family history, no inherited strong mandible, then this is good. This will give me good success results. And if the overbite is positive or even deep, then this will give me good stability. These 3 factors will enhance and will ensure that my results are stable. This is what we call 2x4 appliance. 2x4 appliance is an appliance that is bonded to the 4 incisors and banded to the posterior molar. So we have a band on the posterior first permanent molar and 4 brackets on the 4 incisors, and this is what we call 2x4 appliance, and we can use it in order to correct an anterior crossbite. Usually if we have less dependence on the patient's compliance necessary, the patient compliance should not be a factor, then we can use this appliance. It will give me more controlled tooth movement, and it's efficient if I have more than a single tooth in crosspipe, and it can give me, in addition to anterior crosspipe correction, alignment of the teeth. If you have 3 teeth or more, then, and you want to correct it not by this 2x4 appliance, by removable appliance, then it's important to use anterior expansion screw in order to have an efficient movement and correction of the anterior crosspipe. Patients with a class 3 malocclusion that don't have the 3 successful factors that we talked about, so they have real class 3, not pseudo class 3, they don't have anterior mandibular displacement, they have family history of strong mandible, and they don't have enough overbite to stabilize the results, we need to refer to the orthodontist, because these patients will need growth modification appliances like face mask, chin cup, or whatever appliances that the patient will need, and this will need a specialist. You need to refer to the orthodontist. Now we will come to the crosspipe in the posterior segment. Crosspipe in the posterior segment might be related with temporomandibular joint problems. Weak evidence, but it might be related to this. The management of posterior crosspipe could be by simple grinding of premature occlusal contacts, usually in the primary C's, or we can use simple removable appliance with midline expansion screw. We can use quad helix, which is a fixed appliance used for expansion, or we can use rapid palatal expansion. Again, fixed appliance, but usually it produces more bodily movement and more range of tooth movement. I will show you a posterior crosspipe with mandibular displacement. So this is the patient. These are the midlines. Now the patient is opening, closing, premature contacts, and then he has to shift his mandible to the left. Premature contact, and we will show you now across. Yes, this is premature contact on the cusps, because maybe wide mandible, narrow maxilla, doesn't matter, and then the mandible is trying to avoid the premature contact by shifting to the left. How do we solve this problem? By expansion. As we said, we can use URA, quad helix, rapid palatal expansion, and this is the mechanism we use. We expand the maxilla, and now we look how the occlusion, how the teeth are closing. Open, close, we remove the premature contact. This is how the normal transverse relationship should be. Right, so this is posterior crosspipe with mandibular displacement. Finally, something that we can treat early is the patients with a class 2 division 1 and increased overjet. You already covered the topic about functional appliances, and you know that the best time, the ideal time to use functional appliances should be at the growth spurt, which is beyond 10 years of age. So 10 to 12 for girls, 12 to 14 for boys. But sometimes the patients with such malocclusion, they suffer psychologically. Their self-esteem is affected. Their self-confidence is affected. Or sometimes the risk of trauma is higher than the rest of the patients. So we need, in some cases, to start treatment really early. So we're talking about a patient who is 8, 9, maybe 10. So before 10 of age, it's not the ideal or the optimal functional appliance type of treatment. Here, we call it interceptive orthodontic treatment to reduce the overjet. This will help the patient self-esteem, confidence, psychological well-being, and it will reduce the risk of trauma. Okay, so if you use the functional appliance, it's the same, by the way, the same appliance, the same mechanisms, technique, the same, but we apply it to a younger age group than the one that we should apply at the optimal time for functional appliances. Okay, so these are the main topics that we could interfere early in order to minimize the developing malocclusion or fully treat it.